Good morning. Here to talk to you about deep venous thrombosis and data supporting early treatment. I have no disclosures. Mr. Chairman, the problem with DVT is it occurs in approximately 2 million Americans each year. Approximately 1/3 go on to develop PE. The combined annual incidence of DVT is approximately 2.5% to 5% of the adult population. It recurs in 5 to 10% of patients per year after anticoagulation, and recurs again in 30% of patients 8 years after anticoagulation. The most feared complication of acute DVT is iliofemoral DVT, and incidence happens in 1 case per 1,000 person years. And the most powerful predictor of post-thrombotic syndrome is the presence of iliofemoral DVT with a hazard ratio of 2.23. Over 5 years, if treated with anticoagulation, iliofemoral DVT goes on to present in 70% with persistent obstruction, 90% venous insufficiency, 40% venous claudication, and 15% with venous ulceration, so extremely morbid. Predictors of PTS are involvement of the common femoral and iliac veins, previous ipsilateral thrombosis or recurrent DVT, higher body mass index, older age, and female sex. Again, iliofemoral DVT is the strongest predictor of PTS. So why care about post-thrombotic syndrome? Post-thrombotic syndrome is the end-stage sequela of DVT resulting in inadequate treatment of acute DVT from chronic subclinical DVT. When the acute clot does not resolve, the clot hardens, leading to chronic obstruction. There's also venous valve damage, calf muscle dysfunction, inflammation, creating a venous outflow obstruction, venous hypertension, venous valvular reflux, and significantly worse quality of life scores in all studies across the board. So extremely morbid complications in the ensuing years afterwards. So the goals of clot removal are obviously catheter-directed thrombolysis, but is to diminish inflammatory response, preserve vein wall integrity, restore patency, and preserve valve function, and decrease ultimately PTS, which follows several years afterwards, and decrease recurrent DVT. So what has been the standard previously, they'd been generally treated with anticoagulation alone, either unfractionated or low molecular weight heparins, Lovenox, Coumadin previously, and now with the newer agents. Earlier trials subsequently showed systemic thrombolysis, particularly streptokinase, and it showed reduced thrombus, but had 3 times increased risk of bleeding. Trials generally were focused on mortality, hospitalization, bleeding, but what about PTS? Little press. So the evidence to support intervention are the Jib Trial. It was the first and foremost that came around in 2002. It was a randomized trial, relatively small series. They looked at iliofemoral DVT within a short time frame of approximately 10 days. They broke it down into anticoagulation and streptokinase initially infused in the clot with the pulse spray technique versus low-dose anticoagulation. Results at 6 months, iliofemoral patency in 72% of lysis patients versus 12% versus those anticoagulated. Valvular function in 89% of lysis patients versus 59% of those randomized to anticoagulation alone, and complications were minimal. The Torpedo trial subsequently followed in 2012. It was a slightly larger study, but again, institutional. It was randomized. Percutaneous endovascular intervention versus anticoagulation alone. The primary outcome was recurrent VTE at 6 months, and in the percutaneous group, 2.3% versus 14.8% in the anticoagulation alone. Post-thrombotic syndrome in the percutaneous group of 3.4% versus 27% in the standard anticoagulation, obviously significant. And they use a variety of devices, including the trellis, balloon valvuloplasty, and stenting to follow up as well. So ultimately, in patients with proximal DVT, percutaneous endovascular intervention is superior to anticoagulation alone in reduction of VTE and PTS. This benefit appears early in the course of treatment and it extends out to 2.5 years. So the CAVEN trial came along. It's a slightly bigger trial. It was a randomized open-label multi-center trial in Norway. Iliofemoral DVT with a longer duration, less than 21 days, the upper half of the thigh, common iliac vein, or combined iliofemoral segments, so multiple segments. There was no anticoagulation prior to trial entry for greater than 7 days. And they looked at 200 plus patients, catheter-directed thrombolysis with alteplase, upwards of 1 day out to approximately 96 days out of treatment strategy versus standard therapy alone. And they followed up with adjunctive balloon angioplasty and stenting for 50% stenoses. At 6 months, iliofemoral patency was 64% in the lysis group, 36% in the controls, with a risk reduction of 28%. Functional venous obstruction, 20% in the lysis group, 49% in the controls, with a risk reduction of 29%. Venous insufficiency was no different. 1 patient had a major bleed, 2 had essentially clinically relevant bleeding in the lysis groups. At 24 months, catheter-directed thrombolysis had post-thrombotic syndrome at 24 months in 41%. Standard therapy alone was 55%. Iliofemoral patency at 6 months was 65.9% and 47.4% in the standard therapy. 20 had bleeding complications in the lysis group, but only 3 were major, 5 were clinically relevant, 4 had non-bleeding side effects. There was no difference in recurrent DVT or PE or death. Absolute risk reduction was 14%, and the number needed to treat was 7 patients. So they surmised at the termination of the procedure, the trial, catheter-directed thrombolysis should be considered in patients with high proximal DVT and low risk to bleeding. So the ATTRACT trial, a lot of press. Unfortunately, in case you've read it or heard it, not great results. And this was just recently released at London at the Charing Cross meeting. ATTRACT fails to meet the primary endpoint, but experts do agree on hypothesis generating. So some of the details that we do know about it, again, this is unpublished and there's no manuscript out yet. The primary outcome for PTS between 6 to 24 months, as measured in the Villalta scale. The trial showed that PTS percutaneous catheter-directed lysis patients had a 46.7% PTS rate and 48.2% in the medical group at 2 years, non-significant. There were significantly more instances of bleeding in the interventional arm versus 1.7% in the control arm. There were no fatal or intracranial bleeds in either arm of the trial. And percutaneous catheter-directed thrombolysis was less effective in older patients greater than 65 years. And the results showed early symptom and PTS severity, and the patients presenting with an iliofemoral DVT had better results than those treated for a FEMPOP DVT as well. Although, again, these are unpublished, and there's currently no manuscript as of yet. The Dutch CAVA trial is currently ongoing and randomizing. It's 180 patients is the target for iliofemoral DVT less than 14 days. They'll specifically be using the ECOS endowave ultrasound thrombolysis catheter. Primary outcome will be PTS, secondary outcomes, quality of life, recurrent VT, and clot lysis with inflammatory markers. Their target end enrollment date is 2018, and they'll be looking at all these markers out 5 years as well. So stick with the guidelines. If you're going to be doing this, and this is obviously a data-driven talk, stick with the guidelines. There's newer chest guidelines that are currently out, and believe it or not, they really don't delve a whole lot into iliofemoral DVT, but they do state acute proximal DVT of the leg. They do suggest anticoagulant therapy alone over lysis. In the fine details of the comment, patients who are most likely to benefit from catheter-directed thrombolysis, who attach a high value to PTS and a lower value to the initial complexity, cost, and risk of bleeding with lysis, are likely to choose lysis over anticoagulation alone. So they leave it up to the physician's discretion. Acute DVT of the leg, they suggest not using compression routinely for PTS, whereas before they did. Now it's only to control symptoms. Interestingly, Meisner, in his 2012, so it's somewhat dated, practice and guidelines put out by the SVS as well as AVF, they recommend early thrombus removal in selected patients with a first episode acute iliofemoral DVT, symptoms less than 14 days in duration, low risk of bleeding, ambulatory and good functional capacity, and an acceptable life expectancy. It's a 2C recommendation. Early thrombus removal in limb-threatening venous ischemia, aka phlegmasia, they recommend proceeding with lysis. It's a 1A recommendation. Isolated FEMPOP DVT can be managed with conventional anticoagulation therapy because there's currently insufficient evidence to support early thrombus removal strategies in this patient cohort. And it's a 1C recommendation. They recommend against the routine use of IVC filtration in conjunction with PCDT in the iliofemoral venous segments, relative risks of benefits versus periprocedural retrievable filter in undergoing lysis, those with thrombus extending into the IVC or markedly limited cardiopulmonary reserve, and they recommend the use of self-expanding metal stents for treatment of chronic iliocaval compressive lesions that are uncovered by any of the thrombus removal strategies, and they suggest that stents not be used in the femoral or popliteal veins. They recommend that patients managed with early thrombus removal also be treated with anticoagulation. And in closing, Take-home message, percutaneous lysis works for iliofemoral DVT. Know your tools and pick the right patients. Know the current guidelines. Evidence is slow in mounting. We are eagerly awaiting the ATTRACT manuscript and the Dutch CAVA results. Thanks very much.